Hi there. My name is Mitchell Hoyer, and I'll be talking to you today about Chemsex and how healthcare workers can apply harm reduction techniques in interactions with LGBTQ+ patients and clients. Thank you for taking the time to learn about this important topic. My pronouns are he, him, and his, and I'm presenting this information because I care about people who use drugs, and I care about my LGBTQ+ community. I'm fairly active on Twitter, where you can find me at Iowa Mitchell, and I'll include more of my contact information at the end of this talk. Before I begin, I'd like to recognize possible biases I may bring to this topic. I'm a volunteer for Iowa's statewide harm reduction coalition. I'm a cisgender white gay man, and I am a medical student at the University of Iowa who will graduate in May of 2021 and go on to pursue a career in emergency medicine. These parts of myself and my experiences make me who I am, but I acknowledge that they may cause some biases in my approaches. I am currently presenting this information from Iowa City, which is on Sauk and Meskwaki land. I'd encourage you to consider what occupied land you are currently on as well. All right, in the next 15 minutes, I'd like to cover some ground. First, I'll give a brief description of Chemsex, followed by communities we see activity in more predominantly and what drugs are used. Then we'll review routes of administration, some literature statistics, and end on how healthcare workers can screen for Chemsex activity or history in their patients and clients, and what they can offer as far as support and treatment options. I'm passionate about this topic and continue to learn more, so please don't hesitate to contact me with questions, comments, or concerns via Twitter or email. All right, what is Chemsex? Chemsex, also known as party and play or PMP, is the consumption of substances to facilitate or enhance sexual activity. The term chemsex is more predominantly used in Europe and among researchers, whereas PMP is the more popular term in America. Multiple substances are often combined during chemsex to shift boundaries, delay orgasm, extend sexual encounters for hours or days, and/or intensify sex. Many people engage in chemsex, and for different reasons, but there are two communities we know engage at higher rates. First, let's talk about the MSM, or men who have sex with men community. The term chemsex and much of its history began in the queer community, particularly at the peak of the AIDS crisis in the 1990s. Chemsex is deeply tied to the queer and sexual liberation movement, but that's a talk for another day. MSM individuals may choose to engage in chemsex for a variety of reasons, including discovering new sexual techniques, taking sexual risks that internalized or societal homophobia and stigma may otherwise prevent them from feeling comfortable doing, facilitating sexual role switching between top and bottom roles, and they may choose to engage in chemsex as a coping mechanism in response to new diagnoses. The other group of people who engage in chemsex at a higher rate are sex workers. Reasons for their activity may include staving off hunger, being able to stay awake longer, which allows them to see more clients, and again, chemsex may be a way to cope with adverse experiences. Moving on to which specific drugs are used during chemsex. Definitions vary, but commonly used drugs include meth or methamphetamine, MDMA or ecstasy, alkyl nitrites or poppers, ketamine, GHB or gamma hydroxybutyrate, and GBL or gamma butyrolactone, and mephedrone. When we think of chemsex, though, we mostly think of meth, GHB or GBL, and mephedrone, as these chems offer a specific high uniquely sought out for sexual enhancement, including decreased inhibitions, increased libido, and increased stamina. So, how are meth, GHB, and GBL, and mephedrone used exactly? And what are some fun epidemiological facts regarding chemsex? Well, I'll tell you. When healthcare workers interact with anyone who uses drugs, it's important that they understand the method of use, of which we see 4 routes of administration predominate. First, let's talk about snorting. Snorting a drug brings on a slower high that may last several hours. Ketamine and cocaine use favor snorting, although some may choose to snort other drugs or use these drugs in other ways. Smoking, as compared to snorting, has a much quicker onset of effect. The high is less intense than injecting, though, and you're unable to get as large an amount into the body at a time. Booty bumping is performed by drawing a drug of choice into a syringe without a needle, inserting the syringe into the rectum just past the pectinate line, and injecting the contents into the rectal vault. The highly vascularized area slowly absorbs it into the bloodstream, creating a less powerful initial high, but allowing the user to take in higher amounts at a time. Finally, injecting, often called slamming, offers the most intense high. Note, though, that intravenous injection techniques may vary greatly, as many people who use drugs either learn from peers who use drugs or are self-taught. Knowing how someone gets a drug into their system changes what harms they may be at risk for, so please remember to ask. The primary peer-reviewed source of information on Chemsex, which focuses mostly on the MSM community, is a systematic review published in 2019 out of London, and it gives us an idea of prevalence, drug use settings, sexual behaviors, demographics, and psychosocial impacts related to Chemsex. Of all HIV-positive MSM, approximately 3 in 10 report engaging in Chemsex. 5 to 12% of people who have engaged in Chemsex report sharing a needle with someone else during an interaction. And the median age of Chemsex participants ranges between 32 and 42 years old, although younger and older participation is far from uncommon. Of all MSM who engage in Chemsex, 3 in 10 state that they have had condomless anal intercourse while high. This percentage increases significantly if meth is the drug of choice. A quarter of all MSM who engage in Chemsex state that it has had a negative effect on their life, and 14% report taking time off from work directly because of their Chemsex activity. You cannot talk about Chemsex without talking about technology. Dating apps have exposed a large portion of our society to drug use, particularly in a sexual context, and have played an important role in the popularity of Chemsex. The modern gay sexual experience often involves marketing and communicating desires and needs online, but still present internalized and societal stigmas of these desires match these modern connections particularly well to sexual disinhibition using chems. Thus, technology offers a gateway into the world of Chemsex. So, how can healthcare settings screen for Chemsex history or activity? As with any patient, people who use drugs deserve respect at a basic level. This comes from acknowledging stigmas, validating individuals, and ensuring goals and plans are made with the patient or client's voice playing an important role. Harm reduction experts out of Pittsburgh, Pennsylvania published an article in 2017 that identified 6 principles through which healthcare workers can improve the provider-patient relationship and subsequently improve health outcomes. I'll briefly cover each. Humanism is recognizing that behaviors and decisions do not occur in a vacuum. Although someone's actions may put someone at risk of harm, those same actions may also provide some benefit to them. Pragmatism is at the heart of harm reduction and transformative justice work. Many human behaviors fall into a gray zone, neither fully bad nor fully good. Healthcare can be delivered in this gray zone with care messages that center reduction of harm rather than moral standards. Individualism asks providers to look at each individual client or patient's abilities. I recognize the irony in this presentation, attempting to give some kind of universal approach to interacting with people who engage in Chemsex, but the truth is that we must tailor each goal setting and treatment planning visit to the individual. Autonomy is all about respectful relationships and giving others control over their own bodies. Incrementalism is recognizing that reducing someone's risk of harm is a journey, and like any journey, there inevitably comes roadblocks, hiccups, or even backwards movement. We can plan for these as best as possible and tackle difficulties as they come, and then celebrate positive movement. With the journey in mind, it's important not to give up on someone. People can be held responsible for their actions and educated on the impact of their choices, but termination of a relationship helps no one. Healthcare workers who keep these principles in mind in their interactions support their patients and clients along a journey towards harm reduction. All right, back to Chemsex in our clinics. One way to screen for it is in the waiting room with a survey. This example comes from the 56 Dean Street Clinic, a premier clinic in London founded by David Stewart, a man often credited with coining the term Chemsex several decades ago. I'll include links to a page on his website specifically for healthcare workers interacting with people who engage in Chemsex at the end of this presentation. If someone screens positive, then a healthcare worker can probe further. As with anything, knowing the language and terms used in the Chemsex community can make someone feel more comfortable in a setting where people who use drugs and people who identify along the LGBTQ spectrum historically have faced mistreatment. Showing empathy and attempting to understand their journey is a crucial first step in supporting someone. Questions to ask may include, how long do you stay awake for? We're learning more and more about the importance of sleep in so many aspects of our lives, so addressing this in a healthcare setting is important. Ask if they have had any bad experiences, such as non-consensual encounters or violence. For those with chronic health conditions requiring pharmaceutical treatment, do they always remember to take their medications when they're high? If not, how can we come up with a plan together to mitigate this? HIV prevention education is important, but recent studies have shown hepatitis C risk reduction education is very low, including in the MSM community. Talk with your patient or client about the serious risk sharing not only needles, but also lube, snorting supplies, sex toys, or other materials may put them at risk of contracting hepatitis C. With sensitive discussions, it's important to allow the individual an opportunity to follow up and talk about incorporating safety into their Chemsex plans. Again, though, with the harm reduction principles in mind, it's important to be pragmatic and respect the goals of the individual. Finally, let's talk about what to do if someone screens positive for Chemsex history or activity. First, let me commend you for listening to this talk. A study out of Seattle surveyed 260 providers from the American Academy of HIV Medicine who were able to prescribe pre-exposure prophylaxis, or PrEP, for HIV. 78% stated that they would start someone on PrEP if they were an MSM with an HIV-positive partner. But this willingness to prescribe dropped nearly 30% when asked if they would prescribe the same medication for an IV drug user regardless of their sexuality or gender. We all carry biases, and you are actively working to reduce yours around a uniquely vulnerable population, so thank you. Once Chemsex activity or history has been identified, the visit goes similar to other chief complaints. Gather a proper history, ensuring context around drug use and sexual behaviors. Using shared decision-making, set goals, and use motivational interviewing techniques to identify an individual's desire to change or reach their set goals. Establish a plan for returning and make sure any urgent risks of harm are addressed before this follow-up. Refer on to specialists as necessary, and lastly, consider providing them with information and resources that they can use to further educate themselves. Here are some examples of resources I think are helpful. The first is a 20-page toolkit published by AIDS United and the Chicago Recovery Alliance in 2019. It covers a lot of what I've already talked about, with more detail regarding specific risks of individual drugs and routes of administration. They also offer outreach techniques and tips. At the end of this toolkit is this adorable 2-page graphic. Chemsex often happens in a party setting with multiple members present. This graphic offers tips for being a respectful and safe party host, with things like a party and play form where people can document what drugs were taken and in what doses and when. I would recommend printing these out double-sided, laminating them, and handing them directly to your patient or client before they leave your office. One less step for them to find this important information. Again, out of 56 Dean Street in London comes this pamphlet on Chemsex first aid. People who engage in Chemsex often may keep this nearby and refer to it to initially address more common problem scenarios that may arise. These could include what to do if a dildo becomes lodged in the anus, or how to trip sit someone who has taken a higher dose of GHB. As I mentioned earlier, David Stewart of 56 Dean Street has a marvelous website for all things Chemsex. On it, you can find a care plan tab where someone can follow an algorithm based on their goals and find helpful tips and resources for how to reach these goals, whether they be abstinence, reduced use, or just a break. Sex is meant to be helpful, not harmful, and this is all about helping our patients assess what role chems play in their lives. Finally, I'd be a poor volunteer if I didn't plug the Iowa Harm Reduction Coalition. IHRC has 3 main goals: prevent drug overdoses, lead people to substance use treatment, and prevent disease transmission related to drug use. They do this by offering a number of services that prioritize the unique health concerns of people who use drugs, including risk reduction kits, naloxone or opioid overdose reversal medication, syringe cleanup and drop-off, rapid Hep C and HIV testing, fentanyl test strips, linkage to housing and homelessness services, linkage to drug treatment, Hep C patient navigation, wound care, support groups, sex worker support, and so much more. They can be reached by people seeking services or by providers seeking assistance at their 24/7 hotlines in these 2 areas in the state. So that's Chemsex in a nutshell. Healthcare workers can support their patients and clients who engage in Chemsex by providing a safe space for them to disclose these novel behaviors. They can lend a sympathetic ear with a few simple screening questions that may be the first step towards support and recovery. Thank you to everyone who has helped me personally learn so much on this topic. I encourage you to explore these links to learn more about Chemsex and how healthcare workers can help guide people on their journeys. Any questions at all, I'm more than happy to discuss on Twitter or over email. Here are some references I used for this presentation. Thank you so much for your time and attention.